for use. And so that's your user manual in case y'all forgot that. I know I'm horrible at reading those things as well. So looking at it from the limiter perspective, like what are some of the things that are going to help, create the dictation of what exactly it is in terms of the differential. In other words, choosing a non-contact, non-mechanical form of energy, such as laser, or choosing a mechanical form of energy, right? So even though shockwave creates an acoustic wave pattern, once it hits the tissue, it becomes mechanical in nature. Okay. And so with radial extracorporeal shock wave, remember that that energy density is going to be highest at the surface, right at the applicator as you put it on top of that patient. And by the way, also within those dermal layers and subsequently below that, there's a lot of free nerve endings. And so they may not like being touched or poked or hit with something that is overly, pressurized and mechanical. So irritability and sensitivity. People that tend to be in really high pain, people that are often guarding because of high pain. Now, guarding's a potentially another scenario that you can take under consideration. Like, is it a muscle spasm? Is it a hypertonicity? So we're going to say guarding. In other words, almost the adverse reaction to wanting to move or use something because of the high level of pain. Low tolerance and flare up positions. In other words, I put them into a specific position and that causes a lot of pain. And that's like I use that one a lot in particular because we want to put people in their comfortable position. Someone just asked, "Is this being recorded?" It is, so you'll have the wonderful benefit of listening to this again if necessary. So those flare positions can be important. And dealing with one now, they wanted to send this person out for an MRI. And I'm like, well, she has horrible posture. She does not experience any pain during her recumbent positions or lying down. It's really only going to be when she's actually moving. So think about, those and maybe what does that mean? Well, I can't really ask you the question, but what does it mean? Again, I probably want to use something that's going to be non-contact. I use this low tolerance thing a lot, and it's also respective of the psychology of your patient. And this is where I kind of get into, and I talk a lot about patient management, regardless of, the potential device. And again, those are some of the points that we take under consideration. So what do I mean by that? Well, I've got a new patient. I'm a chiropractor, never been to a chiropractor, not really sure, what the experience is going to be like, heard about things, whatever, but not adverse to being treated, but definitely an unknowing. And that's where, utilizing some of those therapies that are otherwise a little bit more comfortable to deliver, and creating that rapport and that trust with the patient. And that's why the limiter in A, should be kind of your go-to with laser. So laser's not going to irritate from a mechanical standpoint. You're not moving the patient around. It's usually, in fact, very, very comfortable, especially high intensity laser therapy, because it can create a warming effect, which again, we're not going to get into the physiology, but if it was acute, would I want to use something warm? It's not increasing tissue temperature, like you are with therapeutic ultrasound and shortwave diathermy. So that makes people feel really good. And if that initiates that relationship with your patient, I find that to be extremely beneficial, because if they are a potential patient for us, we don't want to lose them. Then the interface driver. So we looked at, what is their pain? What does their response look like to the delivery of something? And then what are the problems that we're dealing with? And so we're looking at, tendon, fascia. Do they have localized pain or discomfort on load? So I just said, when someone is standing versus lying down, what are the mechanisms associated with that? And potentially what is their problem? And then the chronic tissue behavior. One of the things we see, for example, in low back pain, is we see adiposity or fatty infiltration of tissue into the paraspinals. And if they have this chronic back and forth of inflammatory bouts, then we also start to see, deterioration of especially the intrinsic musculature. And then there's a whole, neurological effect to that. So taking those things into consideration as well, and what, might be most opportunistic in terms of the treatment, and then limiter C, the capacity or the strategy. Again, this particular patient, they wanted to send for an MRI. 86 years, almost 87 years old, frail, um, mild cognitive impairment. And I'm like, okay, so if you determine she's on, I think, 12 or 13 different medications, amitriptyline being one of them for over 60 years. Yes, you heard me right, 60 years. Um, that in and of itself can be problematic. And it's like, well, you're not going to do surgery on this person. Very, very deconditioned. And how does that impact the overall strategy? The movement strategy limitation. What are some of the things that they can't do? What are some of the things that they don't want to do? And especially in things like activities of daily living, what does that look like in terms of some of the deficits that we need to deal with, and how does that impact what might be going on?